So, well, thank you for the invitation. I appreciate being here. And I did choose, when she asked me to name some dates, I did choose a date where no one would fall. So that's why we're here tonight, but I see it's raining, so we'll try to accommodate that. Sorry about that. So in the next 60 minutes, and everyone in here, with the number of people that I see right now, I would guess about half of us have fallen in our lives, at least half, for different reasons. And from 9 years old, yes. So what we're going to go is we're going to go over not just, I mean, a lot of it's about movement disorder, that's true, but a lot of it's also maybe your partner or your family or your other family member or a friend. Or with you as a movement disorder patient, how can you prevent further falls? So let's get started. So you're going to meet three people, Gloria, Robert, and Alfred. Sorry about okay. Is that better? Gloria, Robert, and Alfred. They are my patients from the Faint and Fall Clinic. I'm with UW Cardiology. And we have a clinic in the cardiology, and I'm also a geriatrician, internist geriatrician, but we work with people not only passing out, but just exclusively falls. They didn't have to pass out to see us. They can have just fallen. So that's the clinic that we have. We've been in existence for about 3 years. And we are busy. We're actually opened up another clinic at the TAC, the American Center, and then we're opening up another clinic in Rockford because we have purchased Swedish American Hospital in Rockford. Not the cardiology service, but UW Hospital has. So if you're ever traveling, you'll know that Rockford, the Swedish American Hospital in Rockford is part of our network. So you're going to meet Gloria, Robert, and Alfred. They're patients of mine. The pictures are different. Of course, I can't put pictures of patients up, but their stories are exactly how they presented to us. And then we're going to talk about living in Wisconsin, and if you're at risk for falls, and how many people actually fall in Wisconsin, and maybe why. Your fall risk equation, what is different about you compared to the person 3 down from you on the equation, both what type of factors you have that may cause you to fall. What's treatment and prevention for a lot of our falls? What works and really what doesn't work? And then we'll get back to Alfred, Gloria, and Robert and talk about what happened to them. They're very, very different people and very different reasons why they fell. And then we'll talk about a bottom line. Really, what's the bottom line when it comes to falls? No matter what age we are, there's a bottom line to everything, right? Or we usually call it the skinny. Just give me the skinny. That's all I need to know. So Gloria's a patient of ours. She's in her 70s. She's a retired school teacher. Whoops, sorry. She's a retired school teacher, and her daughter brought her in for falls. Her falls have occurred going into the garage. Her falls have occurred in the bathroom. These are things we'll talk about, how to identify where the falls are at. And Gloria says, I just tripped. I just tripped over the step. Maybe I've been dizzy in the bathroom. Maybe I was a little bit dizzy in the bathroom. But she can't really recall in different times of day. But Gloria has a history of hypertension, mild memory issues, bladder issues, osteoarthritis, anything else? And a little bit of macular degeneration. So she was falling. Robert is a retired UW professor with Parkinson's. He saw us for multiple falls, and he would get upset because all of his falls, he loves to go to the gym. He still goes to the gym. He comes out to Research Park, to the gym, the workout center. But his blood pressure would just plummet, just drop like a rock, and he would just fall. So it's autonomic dysfunction. Very, very common with people with Parkinson's disease, it can be, or multiple system atrophy, some of the neurological conditions that cause the blood pressures to either go super high or super low, super fast. So we fixed him up. Alfred is a retired minister. He was going to church to, just keep up with things a little bit. He wasn't preaching anymore, but he was going to church to just check on the books. And they'd find him on the floor, and they'd say, Alfred, what happened? I don't know. He never had a symptom. He would just fall right onto the floor. Sorry, what happened there? But luckily, he never got hurt. And he'd just get up. And it happened so quickly. But it happened like 5 years ago, and then 3 years ago, and then twice in this last year. And then his family said, you need to go in. You're falling. It took us a while to figure him out, but we did. So, did you know at the age of 65, 1 out of 3 people fall each year? Did you know at age 72, a person falls every 2 years? And did you know at the age of 80, a person will fall every year? Did you also know a fall, and you do, I know that, represents the initial event in an adult's life that can possibly lead to the beginning of a serious decline, new or worsening medical illness? One of our biggest fears, no matter what age we are, is to fall. We don't want to fall. Bad things can happen with falls. So you live in Wisconsin. Yay! I won't tell you I'm from Illinois, but I did. We got some Illinois. Okay, Flatlanders here. I migrated here 20 years ago, so I've been voting every year, so I think I'm okay. Are we falling in Wisconsin? Yes, we are. Are we aging? Yes, we are. And are you at risk? Yes, you are. Not just because you live in Wisconsin, but luckily, Jane Mahoney was a physician that I trained under in the geriatric clinic who has done amazing work in falls and has gotten the state of Wisconsin on the board to identify people with falls. And so we're way ahead of many other states. That's why we identify more people with falls, okay? Oh, I'm sorry about this. This one is the 5 leading causes of injury-related death in Wisconsin. And all you need to see are the green squares. The 5 leading causes of injury-related death in Wisconsin. So the age groups go from 0 to 14 ages over on the left-hand side to 65 and above near the right-hand corner here. And falls are by far the number 1 reason people 65 in age and older, injury-related death in Wisconsin. But of all the injury-related deaths of all the age groups, falls. So falls we take very seriously. Fall-related hospitalizations in Wisconsin for those 65 and older. Let me move this up a little bit. The darker the green, the more people that are hospitalized for falls, hospitalized in Wisconsin for falls, the darker the green. So if you think about where you live or maybe where you vacation in the summertime, if you have a cabin up north, why would these people in the really dark green areas have more hospitalizations for falls? Think about that for a second.
More people live there.
More people could live there, right, in certain counties. Other places, they may not have as many primary care physicians to go into right away, so the patients go directly to the hospital and are admitted. Many different reasons. We'll go over those in a little bit. Oh, here we go. This is one of my favorite maps. This is why I went into geriatrics. One, I love working with my group and older. And then, but also Wisconsin has a wonderful aging population. We live a long time here, which is great. But in 2015, so those percentage of people age 65 and above in 2015, look at the counties. The darker the color, the dark blue, purple, that is about 30%. If you see the really dark colors up north, 30% of the population in those counties are over the age of 65. 30%. 2030. Whoa. So when I teach our residents, when I teach our medical students, I'll say, if you didn't think about going into geriatrics, it doesn't matter. Because you will be going into geriatrics if you are an orthopedist, if you are a neurologist, if you are, because you need to take care of me and all of us. So this is why we're so empowering these students to learn about geriatric physiology, about our physiology as we age. Because if you don't, you can't help your patients. So high-risk area, are you at high risk for falls? I'm going to go over some of these questions. It may be hard to see, and again, I can send this out to you. So the first question, and this is a fall risk screening. If you answer more than I'm going to go through about 10 of them. If you answer yes to more than 5 or 6, you are at risk for falls. So this is what we give to patients, not in our clinic, but in the family medicine clinics. It's answer yes or no. I have fallen in the past year. I use or have been advised to use a cane or a walker to get around safely. Sometimes I feel unsteady when I'm walking. I steady myself by holding onto furniture when walking at my home. I am worried about falling. I need to push with my hands to stand up out of a chair. I have some trouble stepping up onto a curb. I often have to rush to the toilet. I have lost some feeling in my feet. I take medicine that sometimes makes me feel lightheaded and more tired than usual. I take medicine to help me sleep or improve my mood. I often feel sad or depressed. If you answer yes to 5 or more, you are at risk for a fall. And a lot of us in this room could answer yes to almost all of them. Well, if you think about it, this is what happened to my first patient. The question is, what does running to the bathroom have to do with a fall? People, what happens is, and this is what happened to my first patient, the woman, Gloria, thank you, Gloria. I have a good student up here, she's listening. Gloria, thank you though, that she would get up out of a chair, she'd have urinary, because she'd have bladder spasms. So she'd have to get up and try to make it to the bathroom. And she had her slippers on, or she just loses balance. And to try to get up and move too quickly to the bathroom, we see in our falls clinic, that's one of the number one reasons why people fall, trying to make it to the bathroom, so they don't wet their clothing. So, do you? Well, we need to see you. Sign up. Yep. Good. And there's a lot of ways we can work around if you answer yes to those. And that's why we ask each specific question, because that will help us tailor a treatment plan. So UW Family Medicine in 2014 screened. UW Family Medicine, some of you go to a family medicine clinic at UW. They're not just in Madison, they're throughout the state. So in 2014, they screened. They put out the screen that I just went through for falls. They screened 8,498 patients. That's a lot. 70% response rate, which is even better, right? How many? 3,000 were positive for fall risk. Huge. That's why we get those numbers for Wisconsin. We are identifying those people that have a risk for a fall. Let's go look at some of the facts. Why do some people fall more than others? Because of an increase in risk factors contributing to balance. If you're going to walk away with anything that you remember tonight, it's all about balance. If you cannot balance, you are going to fall. You can be the Arnold Schwarzenegger walking down the hall, but if Arnold can't balance, he's going to fall. You can be as strong as possible. You can walk 6 miles a day. You can swim 3,000 yards a day. But if you don't have balance, you are going to fall. So patients will come in and they'll say, I exercise like crazy. I'm on that treadmill. Oh, I hate that treadmill. But I'm on it, I'm walking, or I'm at the pool, I do water aerobics. I'm like, that's great. That is great. But what's going to keep you upright is balance. Proprioception. Let's go over that. So proprioception, these are the key. I think, do we have to move it up? Is that better? Proprioception. I talk about this with the students and my patients. I say it's all about sensory. It's what you see, what you hear, and what you feel. That will control your balance. If you can't see, I need you to go to the eye doctor. If you have macular degeneration and you cannot see, I cannot fix that. But we can work around that. Your other senses will be better. Some people have cataracts. We take cataracts out. We know by research taking the first one out makes the most difference. It doesn't necessarily make that much of a difference to get the second cataract out, but for a lot of people it will. But by research standards, it really doesn't. Our inner ear, what you hear. It's all about the senses. Hearing, seeing, and feeling. That is going to keep your balance upright, or balance improved, or balance at baseline. And so, because it's all that information coming in, what I hear, what I see, and what I feel, that's going to help me control my body movements. And we can work on that, because a lot of patients will have hearing loss that hearing aids don't fix. They will have cataracts, glaucoma, macular degeneration that I cannot fix, but we can work on other types of proprioception on the balance exercises. And if you look at this man right down here, oh, it's hard to see that, but they have those half-moon balls. And for some people, there's no way you're going to get on that, and I'm not expecting you to. But sometimes we'll just put just the floor. One of my favorite exercises I have most of my patients try to do when they go home is called the kitchen sink exercise, the kitchen sink balance exercise. And if because your kitchen sink a lot. Most of us are, right? And so I need you to stand at the kitchen sink. And if you have a window, that's added bonus points, because I will need you to look out the window, find out what's out there, keep looking at what's out there. And the reason is I need your head up. I need you looking straight ahead. And you're going to stand at the kitchen sink, looking out, yelling at the squirrels, whatever is eating anything, the rabbits, if they're eating your tulips coming up or whatever. You're going to look there, and then what you're going to do is you're going to lift one foot just barely off the floor, barely off the floor. Not this way, not forward or back, just lift it off the floor, not so you're leaning, just barely off the floor, your hands on there, and that's all some people can do right away. That could be that way for months. But that is working on the proprioception. That's working on my one foot's off the floor, I got to think about what I'm doing, I'm looking outside, I'm feeling the other foot, and you just lift that one foot barely off the floor, and eventually you're going to lift your hands off. 10 seconds. Stop. Do the other leg. And I need you near some furniture. I furniture surf sometimes at night when I don't have my glasses on. I'm going to the bathroom, finding out where that furniture's at. So I need you near furniture. Just lift your leg off barely off the floor, 5 or 10 seconds. If you can do that each leg 3 times a day, every day, you will see a big difference. Guaranteed. Guaranteed. I have had some people able to kind of toss the walkers away. Not everyone, but a lot of people can. But it will improve it. If you can just do one exercise, I don't expect everyone to join a gym, everyone to go to PT, OT. There's a lot of things that you can do at home.
And how many times do you do that?
So 3 times on each leg, right? 3 times on each leg. One leg, other leg. One leg, other leg. One leg, other leg. And just start once a day. And again, you design your own. I can do it for 10 seconds. Some of you may be able to do it for 20 seconds. But you want to increase it. If you can get up to a minute, oh my gosh, that's phenomenal. And some people, I have some ladies that just do it 2, 3 times a day because they realize how much of a difference it makes. And that's just the beginning of the balance exercises that you can do. There are so many of these. And that could be another talk that we could go over later on, if I'm invited back. We can go over a lot of those balance exercises. So, if a patient comes in and they have fallen, to us, that is a crime scene investigation. That's CSI. Some of you like that show, CSI? Well, that's what we call CSI Falls. This is our investigator right here. Time to investigate. This is what we do. These are the questions that we ask. Our initial evaluation with a lot of our patients takes an hour, hour and a half just asking questions and examining. A lot of times we bring family members in because a lot of the questions we ask you I didn't think about that. Oh my goodness. Where did you fall? What was the time of the day that you fell? What were you doing when you fell? Were you bending over? Were you picking up something? Were you carrying something down the steps? Were you picking up out in the garden trying to pick up something? I'm telling you all the places that people have fallen. How are you feeling that day? Was that a good day or a bad day? Was that a good energy day, a bad energy day, or just gotten over a cold, or what? What were you wearing? You'd be surprised at what people answer. They had pajamas on still. 2 o'clock in the afternoon. They're a little baggy. I love wearing my same slippers that my niece gave me. Right? Were you carrying anything? What were you wearing? Shoes, slippers, sandals, barefoot? That makes a big difference for some of us. Remember, it's all sensory, what my feet feel, how much support my feet have. We're using a walker or a cane. A lot of us don't like to use walkers or canes in our homes. We can furniture surf. They have the furniture just set up just right to surf through the house. Have you had a recent illness? Have you started any new medications? And I'm including both prescription medications and those over-the-counter medications. And we'll talk about some of those over-the-counter medications causing falls in a little bit here. Did you just eat a heavy meal? If I've had a patient that just fell, of a farmer, half my family is a farm family, and I know they eat a big meal at noon. I know it. I've been at their home. I've eaten that big meal at noon. And they eat a lighter one at dinner time or at supper. And some of us do that too, which is fine. We prefer that, actually. Although, if you eat a heavy carbohydrate meal, all the blood and all your energy is going to go to your gut. And so if you're up trying to do things about an hour, hour and a half later, your blood pressure is going to drop and drop and drop. And as we get older, it takes us longer. You'll see postprandial, post-eating hypotension, an hour or so after we eat. That's why we're so tired. Have you been hydrating? Do you drink alcohol? Any witnesses to your fall? And for my minister friend, Alfred, there were no witnesses. He would always be just found on the floor, and people were like, Alfred, what's going on here, buddy? So, and did you seek medical attention, or did you have any injuries? If Alfred had fallen, and he could have fallen with what you find out he had, and broken any facial bones or broken any arm or any bones or hit himself hard enough to break ribs or really get injured, he went down fast. If that my patient, and then I worry about cardiac issues. Somebody who goes out that fast, I don't like it. Don't like it. So this is what we do if you come in, or if you're to a primary care physician too. They know that we go through all this stuff. We take orthostatic vital signs, lying down, sitting up, standing. That is critical. If your doctor hasn't done that for you yet, or your primary care provider, please ask him to do that. You would be surprised at how much our blood pressure or heart rate changes just by lying, sitting, and standing in our body because of medications, because of illnesses, can't equilibrate. And when you stand up after in the bed, lying down for 8 hours, and you stand up and rush to the bathroom, how many of us get a head rush? Like, oh my goodness. Well, your blood pressure is pretty low at that point, I guarantee. Walking tests, physical exam, mental status exam, labs and imaging for some people, not everyone, medication review, and a spouse or family input if they do come in and want to share, and if the patient agrees to that. Well, the question is, what do we consider low blood pressure? It's different for every patient, right? Okay. It is. And so some patients, they live at 90/60, and they feel good, 90/60. If they get down to 75/50, they just don't feel so good. It's like a diabetic, a person who has diabetes. If they say, I feel terrible when my blood sugar is 85, and other diabetic patients will say, I feel terrible when my blood sugar is 125, because normally it's 350. So it's different for everyone. But a low blood pressure, what we get concerned about is 90 systolic, the top number, and the lower number around 50 or 40. That's low. That's low. So to answer your question. But everyone's a little different. Any other questions on blood pressures yet? So medical conditions. So we talk about traditional risk factors for falling. There is the intrinsic and there's the extrinsic. So the intrinsic is their medical condition. Parkinson's, multiple system atrophy, heart failure, diabetes. Those are all medical conditions. Your lifestyle choices. Do you get enough sleep? Do you drink enough fluids? Do you drink too much alcohol? We see that a lot. In your cognition, are you having mental status changes? Are you having mild memory issues going on? So those are all intrinsic. The extrinsic, external and internal environment, we'll go over those here in just a little bit. And then we all have things that we can modify, risk factors we can modify. We can stop drinking those 2 drinks at night and have 1 or have none. 2 drinks at night for all of us in this room is too much, guaranteed. I don't care if it's beer. And when I talk about alcohol, a lot of times, I work in an emergency department too, I'll say, do you drink? And the person says, no. And I'll say, do you drink beer? Well, yeah. Like, people think alcohol is hard liquor. Right, so, and then same thing about smoking. Do you smoke? No. Do you smoke marijuana? Yes. Or do you smoke cigars? Yes. When you say smoke. So we ask, these are questions we go through. And not we're interrogating, we're just saying, gosh, we got to think about all those things that we didn't think could really make a difference. So things that you can modify, things that you can't modify. If you have gotten to the point where your peripheral neuropathy in your feet, you cannot feel your feet. I cannot bring that back. I am so sorry. I wish I could. I can't. But our goal is to try to prevent it from getting worse. So there's some non-modifiable risk factors that we have to, your eyesight, the macular degeneration, the glaucoma. But we'll work on other things to make up for that. So let's go through a couple. The physiological changes of aging. As we age, what have you noticed? Have you been aging physiologically? Do you move as quickly as you used to? No. Arthritis. Do our minds think as quickly as we want to? No, and I'm in this boat too. I'm right here. I'm one of the baby boomers.
Remembering things as quickly as you used to.
Remembering things? Nope. Now, can we remember way back? Oh, yeah. Oh, yeah. But what you asked I had for lunch yesterday? I don't think so. Don't ask me that. So there's different things that can happen as we age. And, and some of the things we're like, okay, it's just part of aging. We just work with that. But some things we can fix. We can. Then we look at medical illnesses, multiple medications. And this is one that I'm very, very particular on. Most of us in this room are on too many medications. Too many medications. It's called polypharmacy. Too many medications. And then we have social factors that can come into play in the mental status function. So it's not just Parkinson's disease, it's not just multiple system atrophy, it's not just heart failure that causes you to fall. There's many, many different risk factors that accumulate into that equation, intrinsic and extrinsic risk factors that we look at, that your doctor should be looking at, that your nurse practitioner should be looking at and try to modify. Not just them, but this is why we're here tonight, is that you can think of some of the things like, I can fix that, I can work on that. So, medical conditions, glaucoma, macular degeneration, hearing loss, diabetes, neuropathy, arthritis, osteoporosis, heart disease, stroke, incontinence, musculoskeletal weakness, and stiffness. It's like, oh, well, what else is there? Well, that's enough. That's enough. Don't worry, we can work at it. So when you combine age-related physiological changes and all of these pills, boom, fall risk. We can modify a lot of this. So, do you think we take a lot of medications? Who in the United States takes the most medications? So this is Dartmouth, and if you like to get on and look at some research on the internet, look at Dartmouth. If you just do the Dartmouth medication, they'll show you the medication inquiry. This is Medicare. So these are all people at 65 and older, and they look at how many people have gotten more than the average 30-day prescription in a year. So 1 year, one 30-day prescription, or more than one 30-day prescription. So what they did was, for example, in Madison, right here, the darker the color, the more prescriptions. So that dark color, these people in this area here in Wisconsin, you wonder why we have so many falls. Ugh. So all this dark, dark orange, that is 51 to 63 30-day prescription in 1 year. Can you imagine getting that many prescriptions? I mean, most of us, we'll get refills, right? That's not the same thing. This is like new prescriptions. Antibiotics. Oh, they want to try a different one. We want to try a different dose, right? I'm going to decrease your lisinopril. That's another one. So all these changes in your prescriptions, that's a lot. So yeah, 51. But then we have high-risk medications. The Ambien, the clonazepam, the antidepressants, the pain medications. Those are all high-risk medications that when combined with the extrinsic aging process, those high-risk medications, you're like feeding the fall. You're just feeding it, and it's going to happen. Who has most of the high-risk medications? Well, thank God we got out of that one, right? So the darker the color, the more high-risk medications were given out, down in the south area. Look at Madison. Nice and white, bright color up there. Very nice. So,
Do you have any idea why in one geographical area that there's more meds?
so the question is, do we have any idea why in one geographical area there's more high-risk medications given? And more prescriptions, yeah. In that area, if you look back, there's even more prescriptions there, high-risk medications. People can argue about why there's high-risk medications given out there, but some of the higher-risk medications are for some of the aging process. People that, as they get older, they've been given out for years, right? We're beginning to realize that some of these high-risk medications aren't the best. And so a lot of people, as we age, we migrate into the south. And that's what you'll see. There's other reasons, too. It gets into some political territory here, but be careful. Yes?
I would hazard to guess is that in the Madison area where people have more access to hospitals and things like that, compared to where I come from is southwestern Wisconsin, farm communities and things like that. If they get a checkup once a year, they're doing darn good, you know. Whereas we here, I'm very conscious about that. Every year I go in with something, I mean for physical checkup. So I have more access to medications and all that other stuff. That may have something.
Absolutely. And it's access to medical care that could make this difference. And if people doctor shop, and some people in the South, I know just by job descriptions that come to us, that they're always looking for people, doctors to go down there. And so patients have to maybe jump from one primary care to another. And they're like, oh, forget it. I'm just, give me this medication. And it gets very, very confusing. And I've seen a lot of people, I work at the VA as well, and I've seen a lot of veterans that will move closer to Madison just to get, so they don't have to go to the doctor in their home. It gets confusing when you start mixing up doctors here and there. And people that don't vacation, they don't spend the winter in Florida anymore. They'd rather stick around to the dock in the area that they know. And it's just, it's kind of sometimes common sense too, to be around in a safe area. But thanks for that comment. So here are the most common medications that are, cause increased risk for falls. Benzodiazepines, lethal. They're lethal. Lorazepam, alprazolam, clonazepam. People years ago, and some people still do, doctors prescribe, it's rare, but they prescribe them for sleep. And to get a good night's sleep for all of us is like, oh, that's number one. And we know it's important for our health to get a good night's sleep. But the problem is people mix up a good night's sleep with a bad medication, lorazepam. We have noticed that, and there's been a couple studies in the last few years that look at people on lorazepam, and if they start it in their 40s, for anxiety, or it's another medication for anxiety, if they start it in their 30s and 40s, one, it's very addicting, and then two, as they age and they're on that same medication, benzodiazepines, it can contribute, one, to falls, but in particular can contribute to memory issues, chronic memory issues. So you have to be careful. There's also the non-benzodiazepine hypnotics, the Ambien. This is the classic medication that people give for sleep. I imagine, please do not raise your hand, but I imagine there's some people in this room that are on Ambien for sleep. Low dose, on it for years, works, you can still function. There are some people that do okay on Ambien. It's not a medication of my choice for a lot of my patients, and we try to wean them off, but there's some patients I can't, and we just need them to get a good night's sleep, and we hope that they won't have to get up in the middle of the night to go to the bathroom. So, because it can really affect how we move, our movement, our whole proprioception, the sensory, these medications just dull our senses. Absolutely. It's crazy. Trazodone, great question. Trazodone is another medication that we give for sleep. It's great. It should be up here as well. As a non-benzodiazepine sleep aid, I'd almost rather have people on Ambien than trazodone for some people. Now, everyone's different, though. One patient may not respond well to trazodone versus Ambien. So, in whatever you do, the lowest dose that you can use for anything is the way to go. Go low, start low, go slow. Start low, go slow. So if you do need Ambien or the trazodone, the lowest dose possible. Antidepressants. Believe it or not, antidepressants can cause a risk for falls. Antidepressants kind of mellow people out, right? Kind of mellow the mood out a little bit. Don't have the high swings and high lows. But they can also dull our senses and the whole proprioception. And so we know with SSRIs like Zoloft, people are at more risk for falls on some of the antidepressants. Start low, go slow. I'm not saying everything's bad, nor if patients come in, nor do I ever take them off their antidepressants. But some people can be on 2 to 3 antidepressants. And the reason for that is that a lot of antidepressants just make you so like, oh, because you don't want to have those wild swings of depression, anxiety. And then they put another antidepressant on that's more of a stimulant antidepressant, like Wellbutrin, which is more of a stimulant antidepressant. So they put 2 and 2 together. And for some people, that's how they function. That's how they can live alone. That's how they can go to church, go to the grocery store with these 2 antidepressants, and that's fine. But we have got to make sure it's the lowest dose possible when they take them during the day. There's all these different factors that we play into. I'm not saying I take people off, but we look at what else they're on too. Diuretics, the water pill. This is back to the bathroom lady, getting up to go to the bathroom in the middle of the night. Some of us have heart failure. You have to be on a diuretic. You have to get that fluid off. But it's how much you take, when you take it, and what else are you doing in your life? What are you drinking? Are you drinking any, caffeine products? Are you drinking a lot of sugar products? That can all affect how much this water pill works and how much you're up going to the bathroom. Many patients, and I get it, they come in from Rockford, they come in from Northern Illinois, and they don't want to have to stop to go to the bathroom coming up for a visit, so they stop their water pill. And by the time they get here, people who are so sensitive to that water pill, we have to give it in the office because they're going almost into heart failure. That's how so sensitive they are. So, vasodilators, blood pressure medications. Of all the pills that I try to get people off of, if I can, it's on too many blood pressure medications, or they're on the wrong kind for what type of issues they may have with their heart. If they have a diastolic dysfunction or a systolic dysfunction, there's it gets a little confusing when you look at the heart. So many times we have to get an ultrasound of the heart, an echocardiogram. And we can tell by the echocardiogram if there is any damage to your heart, how well your heart's functioning, and do I need to have less pressure on the back side of the heart, more pressure on the front side of the heart. And so what blood pressure medication you're on makes a big difference on how you feel and how you function, how your heart is functioning. And so just ask your doc next time, you're like, am I on the right blood pressure pill? Have you had an echocardiogram? Not everyone needs one, but because otherwise I'll get a lot of emails, I'm sure, right? But things to ask your doc. Pain pills. We know it's in the news. It's in the news. A lot of pain pills are bad, which is true, but a lot of us need the pain pills to function, to actually get out of bed and function. But the problem is they're very addicting, very much like the benzodiazepines, and people are on too many. Too many pain pills, OxyContin, oxycodone, all of these pain pills mixed together. What it does is just obliterate a lot of times our proprioception, our whole sensation about how we're feeling. Like, I don't feel, I'm going to go down the steps. I feel pretty good. I don't have any pain. I'm going to go down the steps, and I'm going to take the laundry basket with me. And what do you find? Bottom of the steps, fallen. Their whole coordination is off. People need pain pills sometimes, although there are some conditions that they're on pain pills for that we can fix in another way. For example, if they have a really bad hip arthritis or bursitis, I may send them to orthopedics to get a little steroid injection or a little trigger point injection. Try to get them off the pain pills if we can. Or to physical therapy to work on those muscles on that side so they don't have much knee pain. So we try to work with what type of pain people have and see if we can fix it a different way or at least augment it so you're on less pain pills. But some people do need them. If there's one thing that we try to get a lot of patients off, depending on your medical condition, is muscle relaxers. There used to be, anyone who come into the emergency department with I tweaked my back. I was working in the garden all weekend. I messed up my back. Oh, well, I'm going to fix you up. I'm going to give you some ibuprofen, and I'm going to give you some Flexeril, and I'm going to make sure your muscles relax. And, well, that's a huge fall risk, right? If my muscles are kind of relaxed and going up and down the steps, driving my car, and the clutch and everything else. We don't like muscle relaxers at all, but certain patients with contractures, if they don't have them, they can't function. Very few people really need muscle relaxers, believe it or not, very few. But those who do absolutely need them. And again, we work with that. The last issue is herbals. When you mix herbal medications, you see this, you can see it in the magazines or you see it, I just heard it, GNC, right? GNC, vitamin, herbal, whatever, that store that's always at the mall. I just heard it driving over here. And they're like, if you buy one bottle of vitamin, you get 10% off. But if you buy 2, you get 20% off. And if you buy 3, you get a free bottle of another mineral or vitamin that we think is best for you. Oh, my Lord. Those are the bad news bears. Don't get me started. 1, vitamins and minerals are not regulated. And there's a huge study done in New York City. They went to Walgreens, they went to CVS, they went to Walmart, they got the vitamin C, they got the echinacea, they got the St. John's wort, and they looked inside these pills to find out if it's truly what they said were in there. Do you think it was? Absolutely not. A lot of it was just garbage. Absolute garbage. Wasting money. That's why these people are millionaires. Where do you think the GNC guy lives? Or gal, I don't care. They probably have a couple homes around the world. This stuff is bad. Unless you've been told by a physician to take this, do not take this stuff. And I'll be honest with you. I've had so many problems with patients with liver issues, with kidney issues on these medications, mixing up with their other prescription medications. I cannot tell you. Especially we've had a couple liver failure patients I've taken care of on this. So be very, very careful on what you take.
Where do you buy good vitamins?
The question is, where do you buy good vitamins? If you're eating a balanced diet and your doctor has not said to you, you have vitamin D deficiency, you have vitamin B1 deficiency, you have vitamin B12 deficiency. If you have no vitamin deficiencies and you're eating a balanced diet, you do not need vitamins. Don't eat them.
What about vitamin C?
Vitamin C is a water-soluble vitamin. When I start getting sick, I agree, I believe vitamin C is good. If I start getting a cold, I'll eat more oranges. You try to get it as healthy, the healthiest way possible, the most natural way possible that you can. But people, we just want that quick fix, right? We want to look like that person on the box. I want to run through the fields of hay and straw and jump around and feel that way. But most of us, and I can bring all the papers and latest research on the vitamins, the multivitamins. Some people need them, but it's rare. It's rare. And what it does cause is more GI upset, causes constipation, and it mixes up with your other medications, a lot of them. I know some of us, I was taking a vitamin when I was a kid, a Flintstones chewable vitamin, right? Popped on the plate every morning. But be very careful. Less is better, less is better, less is better. Some of the healthiest people I have come in here are the Amish community. You think they're taking multivitamins? No. Do you think a lot of the farm country, my cousins and uncles and aunts take vitamins? No. They eat out of the garden. They grow their own food. We have tons of farmers markets here. That's how you want to get all out of your vitamins and minerals. And I'm on record for that. Sorry. Yep. Melatonin. Great question. Melatonin. I have to admit, I'm a Catholic, so I'm going to say 2 Hail Marys here. But I do prescribe melatonin once in a while. I do. I would rather have a patient on melatonin than trazodone. But CoQ10, we've noticed that it actually causes more, there's more side effects with CoQ10, and we're taking all of our patients, most patients are off that now. So, but I have had patients that I try to take them off some of the vitamins and minerals, and they just like, look, my gut acted up, my irritable bowel acted up, now I'm getting a rash, I'm gonna go back on them. I'm like, oh, that's fine. But less chemicals in your body, the better, right? We're trying to feed ourselves all these pills.
I was just told that I needed to take iron pills with vitamin C. Now, where do you go?
No, that's true. No.
But where do you go to buy a good quality vitamin C? I mean, that you know is vitamin C.
Oh, vitamin C. I think, so her question is, you're right, to absorb the iron, you need the vitamin C. So she's on an iron supplement, and it's true. If you're iron deficient, like I said, if you're vitamin B1, B12, iron deficient, you need those supplements. You do. If the doctor tells you need them, but for the vitamin C, that's a pretty benign. It's hard to make a mistake on that one.
I mean, do you eat more oranges, or do you just?
You can, yeah, totally. Don't go overboard on that. Although they're really good right now. You can, like before, you may orange in your Christmas stocking at, that was a big deal. But now you can buy oranges every day of the year. It's kind of crazy. But I think you'd be safe even like at a reputable like Walgreens or CVS for vitamin C. All right, so this is a common scenario. You go in with low back strain. This is called the medical cascade. It happens to all of us. You go into the low back strain. This is just an example. The doctor says, I can fix you up. Or the PA, the nurse practitioner, I'm going to give you some ibuprofen. I'm going to give you some naproxen. And then what happens is, and I may not be able to see this, but ibuprofen and any of the anti-inflammatories go through your kidneys, and they create havoc. And the havoc is in the form of hypertension. So for those patients on ibuprofen every day or naproxen every day, eventually you start seeing their blood pressure creep up. And then your doctor's going to say, oh, your blood pressure's up. You need a blood pressure pill, right? And then you put down a calcium channel blocker, amlodipine, because that's the most common and the most effective, one of the first line blood pressure pills, amlodipine. So then you're on a calcium channel blocker. So you went in with back strain, you're on an ibuprofen, now you got hypertension, now they put you on a calcium channel blocker for your blood pressure. And what calcium channel blockers do, every medication has a side effect, but in particular, calcium channel blockers may cause lower extremity edema, swelling in your ankles. You're like, well, I got to get rid of this. So then what do you go on? A water pill, right? And it's all from a back strain. Isn't that crazy? That's called a medication cascade. We have all been in it, guaranteed. So what do? Well, what we try to do now, especially with low back strain, you can still take ibuprofen, but we do like 5 days on, a couple weeks off, 5 days on, a couple weeks off. We try to switch a lot of our patients to Tylenol if you can take that, if you have no liver issues, and you can take Tylenol. If you can't, there are some patients that absolutely need the NSAIDs. Then we'll deal with the hypertension and we'll deal with everything else. But we try to avoid these medication cascades if we can. So think about it. When you go to the doc, we'll talk about this in just a second. We're almost there. You ask them, how long do I need to be on it? Do I really need it? Is it interfering with anything else that I take? Not only the physician, but the other person you want to ask is the pharmacist. They'll let you know. Good question. The question is, should we just try therapy exercises instead of all this? God bless you. I'm going to give you an A+. Therapy, absolutely. And they have known, remember years ago when we had back issues or back strain and oh, you need bed rest. You need to lay on the sofa for a few days. Not anymore. We tell our patients, up and about every 2 hours, get up off that sofa, get up off that chair. We need you moving. We know that too much of the laying around is bad for you. So. Thank you. Herbals. I don't go after all of these, but these are all the side effects from some of the herbal medications. In particular, if you're on warfarin and you take garlic or St. John's wort or ginseng or saw palmetto or ginger or cranberry, you got to be really careful. So some of these herbals, a lot of patients take them. They don't want to tell their docs. We prefer that you tell us. I don't yell at my patient. I'm like, please tell me if you take them. And if they say, I'm going to continue taking them, I'm like, okay, that's fine. We just got to make sure everything else is okay. I'm going to work with you here. But what they'll cause is sometimes it will cause your INR, your Coumadin levels to go too high or too low. If you're on anticonvulsant, if you're on seizure medication, and you take St. John's wort or valerian or ginkgo, it can cause problems with the seizure threshold. You may have more seizures, or you may be so sedated from the seizure medication. So a lot of these, what they're finding, and there's a whole thing at the CDC looking at herbal medications, how they mix with our prescription medications, even though we know the herbal medications are not as accurate as we always think. But they have some of the herb in it. We know that. So be very careful. So here's the game plan. On all your medications, low dose and titrate slowly. If a doctor gives you 2-3 prescriptions at one time, you say, I was at a lecture once, and this woman up there said, I should never start more than one medication at a time. Can I do that? This is what I want you to tell them. And I tell our residents this, if you're going to start, unless they absolutely need 2 or 3 medications started right away, then you can start them. But I never start a bunch of medications right away. I don't know what if they start having side effects, I won't know which one it is. That's terrible. So what you can do, you may need, if you just went in with a heart attack and you came out with 5 new medications, and what I've got some of my colleagues to do is start one, the next week start the next one, and the next week start the next one. But other people who are in heart failure, we need you on these medications. So we start low and go slow. So if your doc says to you, I'm going to start you on a bunch of medications, always ask, 1, can I have the lowest dose possible? And 2, do I have to start them all at once? Can I space them out a little bit? So, frequent medication reconciliation. Please bring in all your medications. We used to do that a lot. Now with Epic or HealthLink, and it's all on the computer, we can kind of see what you're taking. But at least what I had my parents to finally do, and I did this for them, is to type out make a medication list. And they carried it in their purse and their wallet. They would winter in Florida, so they took everything, all their information with them. There's surgeries and things like that. But if you're going to carry anything around in your wallet, because I tell you, if you're in God forbid, if you're in an accident or you fall and you come into the emergency department, everyone's just like moving fast and furious and getting you taken care of. And they'll say, what medications you're on? You're like, I don't know, something for blood pressure and something else. And it's hard to remember under this craziness, right? So what you do is you're like, hold on. You get your purse, you pull out the list, and you say, here it is. That's what I'm on. And those are my allergies. So if there's other thing you can do when you leave here tonight is go home and make that list. Sometimes it's tiny writing, but keep it in your wallet and your purse. It's so, so important.
We've done that for 20 years. We have a list. She has mine, I have hers.
Oh, fantastic. And a lot of people, if you have them on the computer, you can just go edit them, right? So 20 years, that's impressive. That is impressive. Good for you.
The outreach gal gave me a card to fill the medications out and a little plastic pocket with a magnet on it. In the event an ambulance had to be called, they recognize this little plastic pouch, and they can go right there and see what your medications are.
That's true. That's good. And some of them are putting it on the refrigerator. That's another place. If you want to put it on the fridge and the ambulance comes in, you say, medication list on the fridge. Or they'll go there. A lot of our ambulance folks will go to the fridge and look if you have medication lists, but not only that, but what you want done in your life if something were to happen. So the other thing I say is, patients will come in and they'll say what medications you're on. I try to empower my patients to say, you don't have to know the exact dose. You don't have to know the physiology behind your medication, but you should know why you're taking it. Why are you on lisinopril? Why are you on Depakote? Empower yourself. It's just like if I were to I'm dead serious. If I were to take my car in and the mechanic comes out and says, well, little lady, I'll say, well, it's not little lady here. Then I know it's going to be a big bill when I hear that, right? So I say, well, ma'am, it's the carburetor, but then it's the clutch, and then, I don't know, all these terms that they throw out at you, right? And if you're not savvy about the car, you're just like, well, when will it be ready, and how much do I owe you, right? And so what I do is I try to like, okay, thank you for the information, and then I go and scour and read about it and call people I know that know about cars and things like that. And I say the same thing to my patients. I'm like, my father used to say, a good physician's like a good mechanic. You know, they'll kind of look over the whole body. They'll look over the whole engine. They'll try to figure out what's going on there. And the same thing about you as a patient. Empower yourself not only to know about your car, but to know about your body and what you're putting in it. And so when you list that medication list that you have, write down, there should be a column what you're taking it for. And then if a doc says, I need to put you on a blood pressure pill, you say, I'm on 3 blood pressure pills. Because I looked up what these pills are for, and I'm on 3 of them. Are you sure you want to do that?
If your information is in my chart, can they access that? I thought about that one day. I thought, can other doctors or other places, other people get access to your my chart?
No. Can other people get access to your my chart? I've never gone in a patient's my chart. I mean, I've gone in to send a message.
But there's a lot of information there.
There is, yeah.
See, and I thought about that one time.
Yeah.
Is it possible for anybody else to access that in any way?
Just you or the physician. Even the check-in folks can't access that.
But an out-of-town doctor could never get
No, no.
I mean,
The question is,
no
can...
way he could be given permission. I mean, I want him to.
No, no. The question is, can other town docs get permission to your my chart? No. But would you say that if any of you doctor at UW or at Dean or at St. Mary's, we can hook into that with HealthLink, right? I can hook into Beaver Dam. I can hook into Dodgeville. I can hook into Divine Savior and get into all the charts that my patients come in from out of the country. But I don't get into the my chart. But I'll think about that.
That was one of the I mean, when the whole thing first came out, that was to me was one of the advantages. Was that if you were in some other part of the country, somebody could get
No.
medical information.
No. No, because we see patients that, you know, they'll move to Madison, they're from California and live with their family, and I can't get access to anything. It's all paper, faxing in and all this stuff.
There's a county in Indiana where I have a friend who's put the system up where the ambulance drivers, for instance, can get into the system to get that information.
So she's saying there's a county in Indiana where the ambulance drivers can get into the chart information. Usually they can't, and I've heard about this, but it's very select information, if you think about it. Because some of these people that...
What medications are you on?
That would probably be and then your medical history, and that'd probably be it. Yeah, and that'd be fine, that'd be great. Pretty soon they're going to have, just like our pets, the chips. Stick around for that one. That'd be good.
My husband fell and did not have a telephone number to contact me. And so, since his fall, we have gotten ID bracelets,
Oh, fantastic.
which have, these are called interactive, and we actually typed in our medication list. There's a PIN number on the back that's just for us, and the serial number of our bracelets.
Do you remember? So she has a bracelet that has the phone number, and then people can access. And we have had patients that come into the emergency department that we've taken care of, and they'll have the bracelet on, and we can access all this information. And it's usually a medication list and numbers.
My husband's name and his year of birth. It has my name saying I'm his wife and a number that I can be contacted.
Good. Do you remember where you obtained that?
It's an organization called Road ID.
Oh, that's right. It's Road ID, and if it's ROAD, like a road, ID, and I've seen this in the back of bicycling magazines. But if you were to just Google that, Road ID, you can get information like that on there. So yeah, that's a very good one. A lot of cyclists will wear those because if anything happens. All right, let's finish up here. Thank you for sharing that. I appreciate it. So we talk about exercise, alcohol use, nutrition, and hydration. We've touched on a lot of this. But when it comes to exercise, the key number now, and even on our geriatric exams, is 150 minutes a week. 150 minutes of exercise a week. Do all of us do that? I'm not sure even I do that. That's a lot. That's a lot of exercise per week. So just something to gear up for. Alcohol use, no more than 1 drink a day. Now, when patients also say, well, I just have 1 drink a day. And I'll say, well, what is it? And I think a martini. I just had a patient that fell off the bar stool and called me, broke her leg. She just had a martini. I've been working with her for 2 years. So, but if you make their own martini, they'll say, who makes that martini? Right? Because some of us put a little bit more in that mixed drink than the regular drink. So we've all enjoyed a cocktail. I'm not against alcohol at all. It's just the amount that you drink. That you got to be very, very, very careful. If you do drink, some of us don't drink, and that's fine. And if you do drink, though, be very careful how much you drink at one time. And it's now at our ages, it's about 1. It should just be 1 drink a day. So fear of falling. These are things that if you think I'm okay, I don't really have any issues, but you think about if you need to touch or hold on to things or people when you walk, if you walk very slowly, take small steps, limited movement, or express a fear of falling, that you're getting into the cycle of fear of falling. And what happens is that, and a lot of us in this room are in that cycle, and we limit our exercise, we limit what we're doing, and we just get weaker, we get more deconditioned, and we're in this whole fear of falling cycle. So we have to get out of that. Other things that can happen, social factors, role strain, bereavement. You're just diagnosed with something. You're like, oh, Lord. How am I going to get through this one? Somebody in your family died. Your sister died. These can all impact our social, our feelings, our energy levels, and risk factors for falling, believe it or not. Depression, caring for an ill partner. If you're widowed, if you're single, if you are retired, all of these have different risk factors. And some people have been single all their life, and they say, I like being single. But as we age, we realize how much social connection is so important. And whether you're going to church, whether you're going to card game, whether you're going to the senior center, whether you're volunteering at the schools, social interaction is so, so important. Individual capacity, your ability to cope with what you have. And some of that is just this inner strength that you may have, and some of it's given to you from family members, from friends. A lot of us have that one person, that's 2 people in our life. And if you remember in your working days, and I can even say that now, if I see a certain staff member, a certain nurse, or a certain physician, that just brightens my day. Why is that? Why does that person brighten your day? Are they just an optimistic person? Or do they really ask you like questions when they say, how are you? Do they mean it? Do they look you in the eye and say, I really want to know how you are? Those are the people that you need to connect with. Not everyone. There will be superficial friends. We all know that. But you need to connect with those type of people. Again, the family and support systems. As we get older, if you're going to pick all these, the third one, the support system is the key. So extrinsic, just a few things about furnishings around home. Bad things. We'll start out with chairs that are too low to get out of that chair, right? Oh boy. But you bought that chair 30 years ago. It was a good chair, and you're going to keep that chair. All right, so my dad had one of these chairs. My dad had glaucoma, and he had bad knees. He couldn't see. He was blind by the age of 50. And so he had a cane. Didn't like to use the cane. He had fallen multiple times, broken many things. This is probably why I'm in this department. But what we did and what I learned, I've learned a lot from the physical and occupational therapists. He loved this chair. And so, but for him to get out of it, it was too low. So what we did was just put 2x4s underneath here. Just lifted the chair off the floor a little bit. Life was good. So you can still keep that chair. We just have to work with it a little bit. Other people will put more pillows or harder pillows or wood underneath here to make it rise up a little bit. Terrible chair. These leather deep chairs. Now, I cannot work with that one. I am sorry. We just have to get rid of it. Give it to the nephew or something. We got to get rid of that one. This is the propel right into a fall chair. Right? How many have seen these? Yeah. My grandfather had that one. We were mortified every time he'd push the button. We're like, oh, Lord. And so all of us would run, and wait for them to kind of get right out of that chair. So we don't really like these. If you did get one for Christmas, I won't ask who bought it for you. They'll know it's nice Scandinavian type bed, you know, low to the ground, simple wood. Bad. Who's going to get out of that thing? Right? So just furnishings that are too high or too low. Slick or irregular floor surfaces, floor patterns. I keep saying, when you go into UW Hospital next time, when you walk in, what is the floor pattern? Crazy. You look at the floor pattern. They should have consulted our gerontology folks. It's almost like this in some areas. And for some people, that's just like, that is too much stimulation. And if they have any vision problems, any vision issues, peripheral cataracts, that can really change the whole proprioception and the balance. Slick floors, way too slick. This is way too slick here. And then the too much of a pattern here. You need a little bit different type of pattern. So be very careful. You're going to remodel or anything else, what you have on the floor. Loose carpeting, you've heard this. This is something we hear on the news, right, all the time. This is a fall risk right here. This little bunch in the carpet. Lovely Asian or traditional carpet here, or some people say Oriental carpet, traditional carpet. But the fringe on the end, that's where a lot of people catch their feet. Another lovely carpet, but this is the old shag carpet, right? Bad. We can't walk on that. So and again, a lot of times it's working with patients like, I am not getting rid of that rug. I went all half around the world and I bought that rug. We're like, well, then we'll tape it down. So we get tape and we can tape the rug down. Clutter, avoid it, period. I've had many patients that live at Oakwood, and they brought everything from their home into the apartment in Oakwood, right? So they're just kind of going like this through so we have to work. It's like, okay. And a lot of our visits is like, okay, what are we going to get rid of this month? And so we decide, and that's hard. You know, it's a lot of stuff, a lot of good memories and things that we have, and including myself. It's hard. I look in my attic, and I'm like, I should be getting rid of that. So declutter. Lack of grab bars in your bathroom or handrails, and hopefully a lot of you already have these in you think about places where you may fall. This is where you want all the bars at. And some people are like, oh, I don't want to disturb the nice tile that I have in the bathroom. So what? A couple holes in the tile, you won't see me in the emergency department after a fall. So just put the grab bars in, please. Another thing I learned from my father with the vision issues, my mom actually figured this out. She put yellow tape, and then he could see the steps when he had still some vision left that he barely could see, but he could certainly see that yellow tape on the edge of the step because he would fall on the steps all the time. She put that down and worked like magic. Railings down the steps. Some of us need railings on both sides, not just one side. Poor illumination. Most of my patients, I try to get them to think about night lights and keep a light on in the bathroom. Keep a couple lights in the hallway so you know where you're walking. The biggest mistake you can have is have a dark house and get up in the middle of the night and go to the bathroom. You want to have some lights on, if you can. Footwear. How many of us have these? What are these called? Uggs or something? Or clogs, but there's Crocs. Well, that's a bunch of crock. Don't wear this stuff. They are comfortable. I have a lot of people wearing these, but a lot of people will fall. The rubber will get stuck, you know. All it takes is one fall, just one fall. Your whole life could change. So these are just ideas. And they had these fancy shoes, these rocker shoes. Just don't do it. Just don't do it. Go back to the original nice shoe that you saw your grandma wear, or the nun at church or whatever. Just these are the type of shoes. The good running shoes. Morgan's is a great place to shop. A little pricey. I love them. I'm not on the camera. Sorry about that. But think of a good sturdy shoe that you can use. And who cares about what they look like, right? I mean, come on. You don't have to be all fancy and wear those heels anyway. I don't barely wear those things. Well, you know, it depends. I mean, all it takes is like the slippers. We all love these. Slip on them, and your feet are nice and cozy in the wintertime. But again, it depends on the bottom, what you're running into, and what type of flooring that you may have. And all it takes is like going up and down steps with those. They can get stuck, or you can flip out of your foot. And then you have another foot doesn't have the slipper on it, and you can lose the balance that way. I've had more issues with these type of slip-ons. I'd rather have a slipper with a back on it than just the slip-ons. Oh, eyeglasses. We're almost done. Almost done. Eyeglasses. So what we have noticed in the last few years, and I'm at the point where I have to either choose between the progressive lens or the bifocal. And I've seen way too many people fall with the progressive and bifocal lens because they can't see the step, and especially on the stairs. Is this correct? You see too many steps. And so what happens is, but like, well, what am I supposed to do? This is where people, Walmart, the classic, Walmart, Walgreens, wherever. You go up the curb, and everyone's wearing their bifocals, and they hit that curb, right? And they're like, I don't know where it is, but I'm going to step right here. And then they go. That's where they fall. And that's where the bifocals are, and the trifocals, and the progressive lens. It's a great idea, but as we age, and if we have any of the health issues, it can be a disaster. So a lot of times what I do is get the medium glasses. Like I see you back there. I don't drive that way. But then so you can get medium glasses for reading, TV, and then you can get I know that's a lot of glasses, but if you want to avoid the fall risk, that's an easy way to do it. Or when you're going up and down steps, you always look straight ahead, don't look down. And then some other people put their glasses up here and go up and down. And use the handrail. But don't look down at the curb or the steps a lot. I mean, try to figure that out. But that's where most people fall because they see too many or they just don't see where it's going, where it's at.
So are you recommending single?
I like single. I try to, if my patients can do it, I try a single vision lens. You may need one for driving, but a single vision lens and then the reading glasses. So, things that work, balance training, cataract surgery, podiatry. We have a lot of patients that come in, they need podiatry, the nails trimming, and just taking care of their feet, pacemaker, all that good stuff. Other things that work. Think about it, mental activity, exercise, balance classes, stepping on, Tai Chi, and yoga. That's the trifecta. That's the trifecta. Stepping on class, yoga, and Tai Chi. Love it. If you're going to do anything the rest of your life, water exercise, and then Tai Chi. And I know they have some research going on with the Tai Chi and Parkinson's. Is anyone involved with that here at Research Park? Tai Chi, stepping on, and yoga. Stepping on, and I'll show you the website for this. Stepping on is a program it's a program about balance. And it's for people who are independent, living at home. They may have a walker, but they'd be able to listen to the instructions. And it's like an 8-week course, and it's like $25. It was started in Australia. Dr. Mahoney brought it here to Wisconsin. UW offers it, but actually Wisconsin Institute for Healthy Aging offers it throughout Wisconsin, and particularly throughout Madison. I'll give you the website to look at. They have a lot of classes coming up. It is worth it, absolutely worth it. The only problem I had with one patient, she had bad rheumatoid arthritis, and she tried the stepping on. She loved the class, but the activities that they did caused her rheumatoid arthritis to flare up a little bit. But 99% of the patients I've sent to stepping on class have just loved it, and it really does make a difference. And a lot of people repeat the class. But I'll show you the website to go look at. And what I can do next time, I don't know when's your next talk, but I can bring a handout on some of this stuff as well, on access to it. So for some of my patients, they have problems. They'll get dizzy if they look up, look down, fall risk, right? So we get the grabbers, little things that we use. Grabbers to get things off the shelf. Other people, they have bad back, bad knees, getting out of a bed, so we get them a dancing pole. Not the dancing pole, but a dancing pole. And we did, and this is how it came about actually, was a dancing pole. And I heard this from a daughter who used it for her yoga, well, I don't know what she used it for, but she put it in her mom's bedroom, and then they fashioned a bar on the side, and that's how she gets up and out of bed, and then reaches for a walker. I've used these on several patients, and they actually have real poles, and it's not drilled into the wall, it's just suction cup to the bottom, to the ceiling, and it works like a charm. The other one is getting out of a chair, getting out of a chair, and she can use this pole here as well. So different things that you can use. For your canes, and some of you are not taught, some of us aren't taught to use a cane. Just a couple things about canes. You carry the cane in the opposite to the weak leg, the arm opposite to the weak leg. You size the cane so the top should come to the middle of your wrist. You look forward, not down. Pivot on the stronger leg. So you're carrying the cane in the opposite to the weak leg. You pivot on the stronger leg. When you go upstairs, your good leg goes up first. When you come downstairs, your bad leg goes down first. That makes sense? Good leg up, bad leg down. Cane in the opposite to my bad leg. Look straight ahead. Make sure it's positioned right here at the wrist. Walkers, they're not all the same. Everyone, I see them here. These are fabulous walkers. But they're designed for that person, right? Some people can't, they have terrible arthritis, they can't do the brakes, or they have a part where they, issue where they just lose the ability to stop, and they can't stop the walker. So some of my patients with Parkinson's or movement disorders, they'll go with a U-step walker. Have you guys heard about this? We have a U-step walker back here. Those are great, incredibly stable walkers. They don't let you fall backwards. They're a little bit pricey, but a lot of times the insurance companies will help with the price. Sometimes they don't, but it's a lovely walker. Oh. Fantastic. Yep. Thank you for sharing that. So the U-step walker, it's a little heavy, not super heavy, 20 pounds, maneuver, but the way they designed it is such, it's right here. It's called a U-step walker. Look on that. A lot of times we can work with the insurance companies to help pay for this. I think they're about, what, $700? Yeah. Yep, I agree. Thank you. Right. Oh, really? Yeah. Okay. Oh, fantastic. So he's talking about there's a laser back here on this U-step walker so that it won't, you have to like cross it to get it going. It's a pretty cool walker. Very cool. And I know neurology, you know about it, right, Nancy? And they'll work with you on that. Can we show yours? I saw him come in tonight. This is one of my favorite trekking poles. Trekking poles. These are great. These are fantastic. So a lot of my patients who need walkers, I get them into the trekking poles because they have as much balance with these or even more. You want to share your experience, or are you comfortable doing that? Okay. So so a lot of patients will use the trekking poles in areas of, small confinement areas, and then they don't need them as much. Or if they want to go further, they're walking further, they just have more balance. So you just hold them like this. Shoo away little dogs and little people. When you do buy them, and he has this nice pair, you want to make sure they're adjustable. I had one niece that bought her aunt trekking poles, but they weren't adjustable, and she was holding them way up here. So you want to make sure they're adjustable, and he's taller than I am, but you want it 90-degree angle. And just walk, and they come with rubber tips, so you can walk on the sidewalk. And the tips will come off, and if you go out and you're walking, if you feel like walking in the woods, you have more, that's kind of a sharper tip for winter on the ice that you can use these. These are fabulous. Where did you get yours? Dick's Sporting Goods has them. I know Target has them. REI has them. They're a little bit pricier out there, but they're about $25 or so. Yeah. Trekking poles, I love them. Love, love, love. If you can coordinate yourself with them. Thank you. I saw you walk in. I knew I was going to show you that. The other thing about trekking poles, you do a lot of Tai Chi or yoga with, Tai Chi or yoga with the trekking poles. The balance exercise is here. So twofold for that. All right, we're going to end it here with Gloria, Robert, and Alfred. So Gloria, she was only falling going into the garage and in the bathroom. So it took about 4 visits to figure this out. But we found out that every time she'd go into the garage, one of her cats would try to escape. And what would she do? She'd try to chase it, yeah, but she'd try to bend over. And the cat, for some reason, always waited until she was on that first step. She had one foot on that first step, and the cat started going out the house, and she'd bend over and try to get it, and she'd fall every time. Right? And why was she afraid to tell us about that? Didn't want to get rid of the cat. And so I said, well, why don't we put the cat in a cage? Nope. Didn't want to do that either. So by the 4th visit, we figured out a way that we could humanely put the cat into a different room with a treat, and that she could go into the garage and not fall over and fall. So that was a neat story. The other one, she was falling in the bathroom. And so what happened is she was having pretty bad urinary incontinence, or getting up, had this urge to go to the bathroom a lot. And so we adjusted some of her medications, but she was also taking her water pill too late in the day. So we had her take her water pill earlier in the day and stop drinking all that tea at night, right? And so she stopped going to the bathroom all the time at night. We put a night light in there, and we adjusted some of her cardiac medications too. So Gloria is still upright. Robert, he was our professor with Parkinson's disease and had this terrible dysautonomia where his blood pressure would drop like a rock and then skyrocket into the 180s over 90s. And so he was on carbidopa, levodopa, and some of the other medications. And I talked to Dr. Dent. I work with Dr. Dent a lot with some of our patients with the falls. We were able to adjust medications. If another prescriber, like particularly Dr. Dent or Nancy, prescribes the Parkinson's medications, I do not change those. I always talk to them first. Or if another doctor prescribes antipsychotics or anything like that, we always chat with one another before we make any major changes. But for Robert, we could make some changes. There's some new medications out for people that, when their blood pressure drops so quickly, that we put him on. It worked pretty decent. He could still go to the gym. But what really worked for Robert, for his blood pressure not to plummet, was to wear compression socks, but in particular compression sleeves, because he would go to the gym. He would hate those socks, which everyone does, I do too, to put them over his feet. He liked wearing his cotton socks when he went to the gym. So there are now sleeves out there, and this, I should have brought a pair. The sleeves go from your ankle to right below your knee. It's the same amount of pressure, and you can get these at any of the running stores, at Dick's Sporting Goods. It's the same type of thing, the compression sleeves, but they don't go over your feet. Yes, there are cotton. Go to Berkeley Running Store. Yep. And so we adjusted that, but he needed even more. So then we had to give him compression shorts. You ever see those cyclists out there with the black, same thing, compression shorts? He needed even more. So then he now wears a compression belt only during the period of day where he's about ready, when his blood pressure just drops. But those 3 things, a little bit of medication, makes the world of difference for him. And he can still go to the gym. So we worked with everything that we had. It's not perfect, but it's certainly a lot better than he did. And again, it's not tons of medications. We were just able to get the compression on there. It's the question is what made his blood pressure plummet. It's called dysautonomia. And what happens is with some of the neurological conditions, your autonomic nervous system, your vagal nerve system, it just kind of, for some reason we don't know why, it can fluctuate so much. Some of it's medication induced, some of it's the time of day. And so we changed that. As you know, you're on the a lot of you in here are on medications that you have to take them a certain time, right? To get things to work right, or change the dose of the levodopa versus the carbidopa. There's all dose changes that we think about. And then finally, Alfred. Alfred is our minister, is passing out in church, right? And so we found out that Alfred actually, we kind of figured out it was a cardiac issue, and he had an aortic valve replaced years ago, probably 20 years ago. And when they go in to any type of surgery, they develop, scar tissue develops. This is like cutting your arm. You'll see a scar there after years, right? And so your heart has its own electrical circuit box, in a sense. And this part of your heart has to talk to this part of your heart to make it work. Some of you in this room have a pacemaker. Same thing. Your electrical circuit box is not working. That's why you have that pacemaker, usually the cause. For him, we put in this little tiny, it's called an implantable loop recorder, and we slid it underneath his skin, and it's monitoring his heart rate and his heart rhythm for 3 years. And so he passed out. He finally passed out, and then we downloaded the data, and then we saw he had this huge pause where there was no heartbeat. And so we put in a pacemaker, and he's never passed out again. Because every time his heart starts to slow down, the pacemaker kicks in and makes his heart beat. He's not pacemaker dependent. There's people that have pacemakers that are not pacemaker dependent, but they need it as a backup. And that's what Alfred was. So Alfred's back in church, upright, standing up. So I think I just have one last one. Falls the result of complex multifactorial interactions. You need a good history and a focused exam. Start low and go slow on your medications. Talk to your doctor. Please, please, please talk to your doctor if you've had any near falls or falls. Because if you wait and you have 6 or 7 falls, we're behind the 8 ball. Then we got to go back and try to, come on. We're going to try to, you have 1 or 2 falls, we need to know. We're going to try to help us. Help you, help me. Balance, balance, balance. Whoops. Look at that. Bocce ball, is that what it's called? Bocce ball. But balance is the key. You can run, you can swim, but if you don't have balance, you're not going to stay upright. So think of the Tai Chi, the stepping on class, the yoga, makes a big, big difference. And if you go home and you're like, I'm not going to Tai Chi, I'm not going to yoga, just remember the kitchen sink exercise I taught you.